Hello, and welcome to What is Innovation, the podcast that explores the reality of a word that is in danger of losing its meaning altogether. This podcast is produced by Outlast Consulting, LLC, a boutique consultancy that helps companies use innovation principles to solve their toughest business problems. I'm your host, Jared Simmons, and I'm so excited to have Nupur Mehta. Dr. Nupur Mehta is an internal medicine physician dedicated to improving the quality of life and well-being of all patients, but especially older adults. He has spent his career innovating within the healthcare industry to align incentives between patients, providers, and healthcare payors. Most recently, he co-founded Heyday Health, a virtual-first primary care startup practice to meeting the needs of older adults. The unique challenges identified during the COVID-19 pandemic have generated significant opportunities to improve patient outcomes and experiences, and organizations like Heyday Health are innovating rapidly to shift the delivery model to refocus on the needs of the patients. Prior to Heyday, Dr. Mehta held leadership roles at CareMore Health, the George Washington University Hospital, the Advisory Board Company, Evolent Health, and McKinsey & Company. He is a graduate of Harvard Medical School and the Harvard School of Public Health and completed his residency training at Brigham and Women's Hospital. When he's not trying to fix healthcare, you can find him on the tennis court, in front of the stove or grill, or chasing after his two daughters. Noop, welcome to the show.
Thank you, Jared.
Thanks for joining us today, and I'm looking forward to a great conversation.
Me too.
So why don't we dive right in? Tell me, what is innovation?
Innovation is listening to what people are asking for and designing solutions that meet those needs. When we think about sort of healthcare and the history of healthcare, so much of healthcare delivery has been based around what providers need, specifically physicians need, what healthcare insurers have needed. But I think where we have really let folks down is in not designing or building around the needs of patients, and very interestingly, not designing around the needs of their families or their caregivers, who we know are a very integral part or an important part of ensuring great healthcare outcomes.
Right. Yeah, I'm sure we can all think of so many examples of a lack of attention to that. It's interesting that this industry, more than others, sort of struggles with the consumer, what I'll call the consumer-backed view of innovation. Why do you think that is?
I think part of it, at least in the United States, is just the way that healthcare is paid for. Your listeners, and of course, you know, Jared, that we have this weird situation where there's a triangle between the providers, the payers, and the patients. And historically, the incentives on what each of those parties is trying to achieve are misaligned. So payers, of course, are trying to create margin. They are trying to reduce costs. They're trying to increase their revenue because they are fiduciaries and have a responsibility to their shareholders by and large. That's not true for all insurance companies, but for the big ones, you know, who drive a lot of the healthcare in our country, you know, that is true. Patients, of course, you know, they want to remain healthy, right? And they want to pay the least amount for healthcare that they can, whilst also making sure that they stay healthy. And then, of course, providers are, you know, part of that three-legged stool, and they are often, you know, for-profit engines, right? They're often part of large health systems, and even the quote-unquote nonprofit health systems are also, you know, really trying to generate margin and to gain market share. And so, interestingly, when you think about those three parties, the groups that are most closely aligned are actually the payers and the patients. Right? Because they're both incentivized and very keen on keeping people healthy, out of the hospital, out of you know, acute conditions, using less medicines, using less healthcare overall. Whereas actually the providers, meaning the folks that are thought to be the allies of patients, actually prefer it when patients are sick, right? In our current world, doctors are paid and actually incentivized to treat people when they're sick rather than keeping people healthy.
It would almost be like Apple being incentivized to keep people from coming to the Apple store.
Exactly. Or selling crappy computers because they make money every time that computer breaks down.
Right. That I hadn't thought about it in terms of you want people to show up to spend money, basically, because that's what happens.
Exactly.
And so expecting them to operate from a wellness point of view, really, it doesn't make any sense based on the current structure and the current model, because they're revenue driven, just the way any other financially supported organization would be.
Yeah, right. Exactly. And so that's why a lot of people, when they think about the US healthcare system, they don't call it healthcare, right? It's sick care. We're actually perhaps the best in the world at sick care, right? If you're sick and you have something going on, probably the US is the best place in the world to receive that level of quote unquote technology to receive, your treatment. However, the US might be one of the worst places in the developed world, at least, to receive well care, right? Or to perceive preventative care, or to really focus on wellness. That, in a way, gets to perhaps one of the things, we'd want to talk about, which is, what has limited innovation. And part of what's limited innovation in healthcare is actually this series of misaligned incentives.
Yes.
That physicians, especially, unfortunately, in hospital systems and doctors, are actually not in the business of prevention. They're not in the business of maintaining wellness. I'm one of them, right? I'm a doctor. Like, we get paid when people are sick. And I think that's where I would really like to, if I had, my druthers, where I would love to be able to help change things, is fixing those misaligned incentives to actually reward health, reward wellness, and reward the people who are putatively the advocates for patients, which is the clinicians, to reward them for keeping people healthy rather than simply treating them when they're sick.
Yeah, the misalignment of value and of motivation and incentive seems obvious when you kind of break it down that way. From a provider, payer, patient perspective, it feels like it's, when there's a difference between the preservation of health and the alleviation of suffering or sickness. And as long as the value creation for the provider is in alleviating sickness, in order to alleviate something, it has to exist. So the preservation of health is almost runs counter to the fundamentals of innovation, which is, innovation requires an incentive to change.
Right.
Oh, that's very helpful explanation. Healthcare is such for me personally, and I'm sure for a lot of folks that are outside of the system, it's such a black box in a lot of ways. And your simple model there with the three-legged stool is helpful. But how much external light gets shined into these processes in terms of sort of innovation and collaboration for thinking about new ways of working or new models?
Yeah, frankly, not enough, right? I think that there are some health systems who have, seen the light, to go with your analogy, and have realized that by reducing the opacity and making more clear, say, what the costs of things are, or what ways to put, say, clinicians on the hook for outcomes, have been able to ultimately create that level of transparency. But that's pretty few and far between, right? I think, unfortunately, coming out of, say, the ACA or Obamacare, as it's, often thought of, there was a lot of hope, I think, even back in 2010 and 2012, that some of the things that were being put forward would actually fundamentally transform the way we think about healthcare delivery. And while I think all of those things were well-intentioned, unfortunately, providers specifically have held on, with tooth and nail to keep the status quo the way it is, and have really resisted some of these efforts to build transparency. I actually got a email yesterday, and I just want to read it to you because I think it's very indicative of this lack of opacity, this lack of transparency. So this is from a colleague of mine who wrote to me, "I got a claim on my insurance that says the service I paid for was Kalj Van Buld Vin XPR." So there's no vowels in that. Interestingly, they're sending that to the consumer, right? That's not like they're sending that to me.
Right.
They're sending that to the consumer. And it's absolutely no wonder that when someone receives that, they'd be completely bewildered, of course, but also have no ability to question what the charge was there, right?
No.
Because how could you ever read that
Right.
and know what it meant?
Right.
And even I, as a physician who can maybe even guess what that means, I don't know what most of it means. I know what maybe a couple things mean. I think that the word blood is in there, but that's all I can gather, right? And so part of it is actually, just to get back to this transparency question, I think it's purposely opaque because that prevents people from actually taking, having some agency and pushing back on what they're being charged for.
Right. Right. That's a perfect example. And in that example, I can imagine the tension between the providers and the payers and the patients. As you were saying, the payer and patients have similar interests or similar incentives in this model, but that level of opacity, I could imagine that creating some tension between the payer and the patient.
Right. And this is the funniest thing, right? I totally agree with you. And this is why when when patients get upset about their healthcare costs, they actually blame the insurance companies.
Yep.
But where did the hell that come from? That actually came from the providers, interestingly. And yet the patients never blame the providers for generating this level of opacity or for charging for things that they didn't need. And yet a lot of that is driven from the provider. Now, from this sort of thing about the bill and how you get it and stuff, I'm not sure whether that came from the provider or from the payer, but everybody is sort of, it's like in on the game, right? It's a shell game and everyone's in on it. And, not enough has happened to change, right? And I think that's where we really need to, as a healthcare community, need to focus on making change and innovating, I think is making this work for people.
Right. And I know you are, you see yourself as part of that solution, which is why I wanted to talk with you. But what would the motivator be for someone inside the system? We can talk about you specifically, but it feels like the solution is going to have to come from inside the provider community. And what would the motivators be beyond altruism? Like, how would a motivation be developed at a scalable level to initiate change?
Perfect question. And the good news here, at least, is that there are some now pretty tried and true models for how to actually make this work. Haven't scaled. There's pockets of this all around the country. But the good news is that I think we do know how to do this. And I think the first thing and the thing that needs to really change, and frankly, the way that most other developed countries are set up is, like I was mentioning, incentivizing health. And so how do you do that? The best way, the easiest way to do that is to put providers on the hook for outcomes. So right now, if you think about it, the true person paying the bills, ultimately, at the very end of the day, is all of us, right? You and me and the patients themselves. So it's because it's a big loop, right?
Yeah.
We pay premiums, the insurance companies pay the bills. And so, but we paid the premiums that ultimately paid the bills.
Right.
You see the result of that. But to answer the question, what should happen is, in fact, that providers get a global budget, a budget to manage a population of patients, right? All of whom receive care within a specific ecosystem. And the money to pay for all of that care comes out of that big global budget. In the UK, famously, they have what are called trusts. And essentially they're regions that have a budget, and all of the care from that region gets paid out of that trust.
Understood.
Similarly, imagine that you are in, I don't know, you're in Baltimore and you are part of the Hopkins system. Just picking a random place here. Nothing about Hopkins or anything like that. I'm just choosing randomly here. Such that instead of Hopkins charging for every individual that comes in, the individual person's insurance company, let's say, were flipped around. And instead, Hopkins said to each of the insurance companies they work with, instead of us charging you every time we see a patient, give us a budget for managing the patients that we see on your behalf. And now, if we do a great job of providing them all the care that they need, their well care plus their sick care, and we can do it for less than what they would have been predicted to cost, then we get to keep whatever is left over. And maybe we'll even share it back with the patients themselves, right? They paid a premium. We'll give them a premium discount to incentivize them to stay within the Johns Hopkins sort of network.
Right.
And so what does that do, right? That creates loyalty or fealty between the patients and Hopkins. that creates an incentive for Hopkins to keep people healthy rather than treating them when they get sick. It also gives Hopkins the flexibility to invest in the resources and people and processes and technology systems and even certain interventions, right? And we can talk about what those interventions might be.
Sure.
But some of those interventions might be outside of the realm of what we think of as health, right? So imagine a world where Hopkins does have that big budget. Why they could invest in healthy food or grocery stores or housing or substance abuse treatment, all of the things that traditionally healthcare does not get reimbursed for, they could actually invest in because they know that for their population, it will ultimately reduce costs and therefore they can devote resources to those new interventions.
I see.
So I think that's really exciting, right? When we can make things like that work, it actually aligns payers, providers, and patients towards health and not sickness.
Yeah, no, that makes a lot of sense. I mean, it aligns the incentives. It also creates a scenario where you can create sort of comps, for lack of a better term. You have peers.
Yeah.
So Johns Hopkins has a peer. Right now, you're just treating whoever comes through the door. But if every hospital is responsible for a region, that more aligns their care strategies and it better aligns their, sort of approaches to things, which will make them more comparable and give investors in those systems a way to drive expectations and set benchmarks and drive accountability.
Yep. Right. Exactly. Yeah. Well said.
Now, in that structure, if you kind of move to more of a P&L management kind of model, and I'm oversimplifying, that your description of that system, but how do you offset the incentive to underinvest in sick care?
Yeah, great question. I think there's two parts to that, right? One is the common complaint is, well, what prevents Johns Hopkins from kicking out the really sick patients, right? Because they know that they're going to cost a lot of money and, send them across the street to the University of Maryland or something,
Right. Yeah, exactly.
And also your other question about why not just withhold care, right? Like that's an easy thing to do too. You just don't provide the cardiac bypass because it's $100,000 and, they don't need to spend on that. So I think there's two big things. Number one, these are very important. One is that you have to have quality gating. So essentially saying, let's say the payer is offering this global budget, right? The payer should write into that budget saying, look, if you don't meet a certain set of quality benchmarks, we claw back a portion because you're not meeting the quality expectations, either from a patient experience perspective, right? So if again, using this example, Hopkins starts to withhold care, well, then the patients are going to be upset, right? And then their quality scores will go down or their experience scores will go down. And so then as a payer, who's sort of the ultimately accountable party here, queries their beneficiaries. They say, hey, what did, you were part of Hopkins's group. Did they do a good job? They say, no, they were terrible. So then the payer can call back some. But it's not just experience, right? It could be from preventative care, right? What proportion of your patients got vaccinations, right?
Right.
What proportion of your patients had appropriate screening tests done for cancer? What proportion of your patients had timely access to their doctors? So you could create a scorecard or a way of sort of gating the funds flow such that if you have to hit those gates before you get any money. And the less quality care you provide, the less proportion of that 100% budget you get.
Got it.
The second big thing that's super critical to prevent cherry picking is to ensure that on an individual patient basis, you risk adjust. There are actually some really good models to do the opposite of cherry picking. I don't know if there's another word for cherry picking, but whatever the opposite of cherry picking is, instead of taking the easiest patients or finding the simplest ones,
right?
Risk adjustment actually can create a scenario where hospitals, hospital systems, doctors actually go seek out the sickest patients because on a per capita basis, they actually receive more reimbursement for those individuals.
I see. Some of these systems, like, or these big hospitals that are always in the news, like Mayo and other places, they would theoretically, for taking on the more complex cases, they would get a disproportionate risk adjusted, factored up sort of reward for that.
Exactly.
Understood. Got it.
So let's say an average person was $100 a month or something like that in terms of, how much that the system would receive. A really sick patient, who's twice as sick as the average would get $200 a month. But if you can keep those folks healthy, you have more to work with. And so some of these folks who have done this and have been successful in this have actually shown that focusing on the sick patients can result in better margins because they can actually improve their care such that they're receiving the higher revenue, but they're reducing their costs even more. Whereas a healthy person like you or me, maybe, Jared, who is not using healthcare very much anyway, it's the low revenue, but is also a low cost. And so it's a wash, right?
Right.
Yeah, it creates good incentive. That's a good scenario to have where you entice people to take on the sickest of the sick because they have a chance to fix them, which is great.
Right. And I love that because it doesn't rely on altruism or, a certain set of values or principles to overcome the natural momentum of the market. It sets the market in that direction, which will of its own, momentum take you in that direction. So that's really brilliant. This is a structure countries are already operating under this model is what you're saying.
Countries, certainly, and many doctor groups around the country, many provider organizations are sort of doing this already. And I should say one thing really quickly, which I'm sort of making it sound like doctors and hospital groups and stuff are not altruistic or kind, or they don't want to do the right thing. I don't think that that's the case, by the way. I think that people do want to do the right thing. However, I do also think that they also have to keep the lights on. And some of these things become pervasive even without people ever explicitly acknowledging them, but they're still happening. To the extent that we can couple altruism with, sort of the income alignment, I think that's where you find the real power.
Yeah.
So for the record, there are lots of good people out there doing the right thing, trying to do the right thing. But unfortunately, some of these things do sneak their way into even the best intentions.
No, that's exactly right. And it's a great clarification because when I think of and speak of altruism, I think of it in terms of, like you were saying, the system or the structure. The nonprofit world is built around an altruistic expectation being established within your operating model and your business model. I think that, that necessitates a certain way of operating, and well-intentioned people can operate in that system. People who aren't well-intentioned can operate in that system.
Right.
And it's the same, vice versa, where, you have a profit motive. And there can be wonderful human beings operating within that structure and doing the best they can to be as good as possible, but relying on systemic change to be driven by an altruistic sort of model is just not realistic in a broader sense. So yeah, thank you for clarifying that. That's a great point.
Yeah.
So as we talk about kind of the way things currently are and the way things look in the world in various places, both here and abroad, I would imagine both here and abroad, things look differently now than they did, as we're recording this in November of 2021, than they did, say a year and a half, 2 years ago.
Yes. I mean, I think your listeners, and I know you've probably experienced this yourself, the world, the healthcare universe has completely flipped on its head, right? I mean, Let's go back to March of 2020, right? Where seemingly within a month, what was a very bustling, face-to-face healthcare system in our country almost overnight flipped, right? To almost entirely virtual, or actually not even just entirely virtual. Basically, people stopped seeking care altogether.
Yep.
Even for things that you would not have expected to have anything to do with COVID, right?
Right.
You probably read in the news, right? The heart attacks went down, strokes went down, cancer cases went down. And it's probably not because those things went away. It's because people simply did not seek care. And those things, unfortunately, probably went undiagnosed, unaddressed.
Mm-hmm.
And then sort of over the course of the last, 18 months, I think the peak of the shift was back in, the spring and summer of last year, 2020. But things have gradually, in fits and spurts, started sort of going back to the way things were. But I think we are never going to go back to the almost 100% face-to-face world. And what's happening and what, we're certainly seeing around the country is a proliferation of lots of different ways of engaging with patients that are far beyond the traditional face-to-face model. And to be very clear, why, we had been so reliant on this face-to-face model was not necessarily because people didn't see a better way. It unfortunately always comes back to the rules and the way that people get reimbursed. And in the current sort of fee for service, getting paid for every time you perform a service, it had to be in person, right? You had to do face to face in order to get paid.
Right.
But the loosening of or the situation around the pandemic, and then of course the changes of some of the rules, has really enabled, I think, a significant opportunity to rethink how care is delivered. Because right now we're in a moment where we can say, are we going to go back to the way things work? Are we going to take this as a learning opportunity to make things better?
Mm-hmm.
And so I think that some of these things that have taken hold during the pandemic, like virtual care, like remote patient monitoring, meaning be able to look at what's going on with patients while they're at home and you're in your office or in your pajamas at your own home office, whatever,
Mm-hmm.
are going to, not only should they continue, but I'm hoping that they will,
Mm-hmm.
because we've not seen, at least in my own clinical practice, a really significant drop off in outcomes. And in fact, in some cases, we've seen that people have done better by not having to come into the clinic every month or 3 months or whatever, and that they do better when they're at home around their loved ones in their familiar environment, especially people who are particularly vulnerable, right? People
Right.
who are elderly or have mental health issues or who have, significant physical limitations that don't allow them to easily come into a doctor's office.
I see. So in essence, maybe the pandemic either accelerated or introduced new models into the world of patient care.
Yes, exactly. And I would say that it's probably accelerated, right? None of these technologies are new, right?
Mm-hmm.
Zoom, email isn't new, and patient portals aren't new. And some of these like vital signs monitoring tools are not new. But I think what has really changed is twofold. One is, to your point, a lot of people are forced to use it.
Mm-hmm.
And then I think two, I think we have opened our minds up a little bit as to what the possibilities might be. And so my own organization, which is, Heyday Health, we've really seen that even older adults, the group that people thought could not use technology,
Right.
could not engage with a team of clinicians, not in person or not in the four walls of a clinic,
Mm-hmm.
have actually loved it, right? And they've really embraced this. And they have, maybe it was because they were Zooming with their grandkids or whatever for like all of 2020, and
Right.
they felt like it wasn't a big deal and they got used to it. But folks have really taken to this. And that's, I think, been very heartening from a care delivery perspective, that we can make change and we can do things the right way and meet people where they are and shift a little bit from this provider centric care model to one that actually does what's right for patients.
Right. And how does this new model enable that, to be able to do what's right for patients more often?
Yeah, I mean, I think in a nutshell, look, we think about the old way, right? If you're an older adult, you have to get up in the morning, make yourself breakfast, take your meds, get dressed, get in a car, drive in the rain, snow, whatever. We're entering winter now,
Yeah.
Jared. So, it's about to start getting cold.
Yeah.
Then you have to go sit in a waiting room with a bunch of other sick people. You have no idea when the doctor or nurse practitioner, whomever, is going to come see you. Then you have to go from the waiting room to the exam room. You wait again in the exam room. Then you get seen for 10 minutes. And then you do the whole thing in reverse again, right? You can imagine how difficult that is for older folks. But our model, right? The team is there at the touch of a button. You can be in your pajamas. You don't even have to take a shower, right?
Right.
You can still see your team. Literally, the walking someone around the clinic is no longer there. We can actually spend more time with people, right? Because you click the button, we're there, we talk, we can review all your stuff, we can provide all the patient education. And instead of spending 5 minutes, we can actually spend 25 minutes, right? And that's been a real game changer, I think, for some individuals who, we're used to being sort of rushed through, and who can now we can really spend time with.
Mm. And that spending time, I can imagine, I'm just trying to make an oversimplified analog to my sort of consulting work, but I would imagine 25 minutes of conversation might also lead you to insights that you wouldn't have just with 5 minutes of examination.
Absolutely. A joke that doctors talk about is, if you have 15 minutes and a patient comes in with 3 problems, each of which take 15 minutes, well, what do? Well, you ask them to come back 3 times and you'll address each one of those problems in turn, right? Tell me what your most important problem is. We'll talk about the next 2 visits. And
Right.
Oh, by the way, I'm going to charge you for each of those visits.
Right.
But in this world, right, God forbid something happens in between with problem number 2 or number 3, it's no wonder why they might end up in the emergency room or in the hospital
Mm,
because you weren't able to address all their concerns
right.
within the allotted time. But because we can spend more time with individuals and because we made it so much more efficient, we can actually get to your point, a lot more of what the patient really needs and needs to talk about, even though there's no more time in the day. We've simply just made practice more efficient.
Mm. There are some elements of things where, you need to see something or touch something or bend something to get some understanding of what the challenge might be. How do you bring that into your practice?
Great. Yeah, that's very important. And I should just be very clear that at Heyday, it's a virtual first, but it's not virtual only. So
Right.
all of our patients, their initial visits done in person. So we come to the home, which I think is really, really powerful. Not only is it an opportunity, of course, to be seen face to face and allow us to examine them and look the patient over, head to toe,
Hmm.
but actually we get to really understand the true lived experience of an individual and what their living circumstances are like, what their food situation is like, whether they have pets in the home or if it's a fall risk situation,
Mm,
or whether they can even they have a good place to store their medicines, right? If they need to refrigerate something, right? So there's so many things you can learn about a patient and their life that you don't get by them coming to you in your office, right?
right.
So it's not just about convenience, but it's also about learning, right? We're learning a lot more about them. But then, subsequent to that, we want to make it as easy as possible to reach us. And that could be through video or phone or email or chat or carrier pigeon, whatever works for people. But
Right.
if they ever need us, right? If it ever comes to the point where, they need to be seen again, we can always come back, right? It's not
Right.
like you get that one time in the home and that's it, never again. Because we are local to the patients that we serve, we can always come back. It's simply just a bit of a triage question about whether they do indeed need to be seen in person.
Hmm.
Because frankly, we can do the vast majority of things from afar.
Right. Right. Yeah, I would imagine the 80-20 principle shows up everywhere. So I'd imagine it exists in medicine as well.
Oh, yeah.
Yeah. You mentioned that you're local. Where are you local to?
We launched Heyday Health in Northeast Ohio, in a part of the country that is historically underserved and has sort of low primary care utilization, but also has an aging population.
Hmm.
So, we're really focused on older adults, Medicare beneficiaries. And so that's sort of where we launched. And, we've been really amazed and pleased at how well this model has been adopted. It is, of course, new and,
Right.
new things take some time to really be adopted. But all that being said, I think we've been really pleased at how quickly people have taken to this. With new things, once the word gets around that it's good, that it's convenient, that it's legit,
Right. Yeah.
people
Exactly.
tend to take it on. And we've been lucky to have a lot of word of mouth. So,
Mm.
yeah, Northeast Ohio, if your listeners are interested in learning more, always happy to talk to somebody. You can check us out at helloheyday.com.
Right. You and we met, I don't know, what is it, 10 years ago?
Yeah.
Wow.
Yeah.
Goodness.
Hard to believe. Yeah, I know.
I wish I hadn't done that, man. But we met at McKinsey and met a lot of amazing people, and you're one of them through that experience. So I just want to thank you for joining us. And before I let you go, I want to, ask, looking all the way across everything you've done as a physician, as a consultant, and your entire career, what advice would you offer innovators?
The honest to God truth is to move fast, break things, and fail early.
Mm,
I think the times I've sit around on a whiteboard and just tried to map something out and actually had what I mapped out work out, I can count on zero hands, right? Like the number of times that's worked is zero.
yeah,
That's never
exactly.
happened. And so, at the end of the day, I really feel like you just have to go try something, put
Hmm.
yourself out there, make mistakes, but be humble and willing to learn from those mistakes and then try again, right?
Yep.
And have the confidence that if you do the right thing for people, if you feel like you're operating in a way that is kind to the people you're trying to serve and to your team, at the very worst, even if you fail, at least you've done right by the people that you worked with. And hey, that's nothing to scoff at.
Yeah. Well said. I appreciate you making the time to join us and share those insights, Dr. Nupur Mehta of Heyday Health. So thank you so much for your time and your friendship. And I look forward to watching the great things you do with this organization, and anything I can do to be helpful, let me know. And I just have nothing but respect for the vision and the problem you're trying to solve and the population you're doing it for. So thank you for your service to the community.
Thank you, Jared. I really appreciate you having me. And this was a great, as always, great fun to chat with you. And I wish you all the best as well.
All right. Take care. We'd love to hear your thoughts about this week's show. You can drop us a line on Twitter at Outlast LLC, OUTLAST LLC, or follow us on LinkedIn where we're Outlast Consulting. Until next time, keep innovating, whatever that means.